I'd like to welcome Dr. Jen Bain up here to do a presentation. And I do think she has lots of videos too.
Thank you so much for having me. Thank you, n-Lorem. Thank you for the parents to trust me to being here. And thank you to the mentors out there who have certainly showed me the way and helped me along this path. So I've had the privilege of really working with a lot of wonderful families. I'm a child neurologist. I'm not an epileptologist, but I do a lot of neurodevelopmental disorders. So I'm very interested in genetic disorders that cause challenging behaviors, motor problems like cerebral palsy, and autistic features that might lead to maladaptive behaviors. And so I've slowly kind of found my way here. Interestingly, one of my early mentors was working on nusinersen. And so when I was a resident, I actually started learning about nusinersen, and we were some of the pivotal trials at Columbia. And so that's actually how I got into this world. And so when I had the opportunity to start working with families and working in the same pipeline, it was very reassuring because frankly speaking, we're the ones putting that needle in your child's back. And I need you to trust me. And so the fact that Stan put up that slide at the very beginning saying, do no harm, that is what I need to tell myself every single day. And that really is my job, first and foremost. And so today I wanted to tell you just briefly about the 4 patients that I've been working with. That being said, I will say just my clinical experience, it certainly takes a village. Nothing can happen at one institution, nothing can happen in one company, one nonprofit. It certainly is taking the effort of everybody in this room and beyond this room to kind of move this field forward. So I'll talk about my first 4 experiences, and then I have 2 coming up very soon. Actually, my patient is right down at New York City right now, and we're dosing on Friday. So I'm really excited to be here and share the 4 stories. So case 1 was recently shared by Dr. Wendy Chung, who first put in the nomination for, I think everybody knows, Susanna. So Susanna was one of our first cases here. She started developing symptoms pretty much at infancy, and her development was always delayed. She started having regression of skills before the age of 4. Previously, she had been walking a little bit late, but more or less on time. And she's had progressive spasticity. She's had nerve pain, neuropathic pain. This later led to severe epilepsy, medically refractory, I guess, for some, optic nerve atrophy and visual problems, and progressive cerebellar atrophy. And when I took care of her actually in my training, and then later as one of her physicians, she was mainly relying on wheelchair because her mobility had greatly declined. And the success of her story and sharing with her group has recently come out and described both in this manuscript as well as Stan's recent preprint. So we treated her 2 years ago, and her genetics is a missense mutation with this toxic gain effect in the KIF1A gene. And so just in brief, I know there's a whole list of different genes, and it sounds like n-Lorem is really supporting across the gene families. This is a microtubule motor protein. It really is important for kind of getting information up and down those neurons and those nerve cells. And we know that it can definitely lead to problems leading to motor difficulties, spasticity, individuals with global motor delay, as well as a degenerative course as well. And so somebody had asked earlier about the clinical model and who kind of makes that protocol. And so I will say it's a collaborative effort between n-Lorem having their standard protocol, working with the clinician who actually knows the patient, as well as the family to say what are goals that are important to you, what will make a difference. Obviously the primary goal is safety, but efficacy is right there as well. And so the goal for her, seizures were really a big concern. And these were encephalopathic episodes where she just wasn't as engaged, and hopefully some videos we can share will show kind of how that kind of brain effects really limited her ability to engage on a daily basis. But second to that, we wanted to look at mobility by improving her spasticity. And so she has received 11 doses, the highest of which is 100 milligrams. And so this just shows you the basic algorithm where you have a dose escalation. So we're almost finishing up that 2-year period, and we're still figuring out what the right dose is for her. And so this involves frequent visits and communication and just really working closely with the family and her other clinical providers, such as her epileptologist, to finding what's the right dose and what exactly are we going to continue to measure. So this was really nicely demonstrated in the paper that I showed earlier, but on the top left you can see these were daily seizure counts from the parents, and these were basically hundreds a day of basically these lapses of mental status. And could you imagine your day if you're not really engaged? And this dramatically went down after just 3 doses. And we've continued to see that, and I think that's been a wonderful, wonderful addition to kind of her clinical care as well. In addition, and this wasn't in the first paper, but is in the recent paper that is coming out, we were looking at neuropathic pain. So this wasn't necessarily one of the primary outcome measures, but it's certainly something that affected her on the daily. And she used the term fuzzy feet. And I think that's an important thing as clinicians and researchers, figuring out how do we take what parents and kiddos are telling us or expressing to us and kind of turning that into a symptom and maybe something that we could potentially gather. And so her fuzzy feet is what we've been kind of trying to measure. And as you can see, so the lower the bar, the lower the pain. And so we've actually seen a reduction in her pain scales and her description of fuzzy feet. And we're actually able to track kind of like when that comes back now. And we're trying to figure out, does that aid in our dosing protocol. And actually, excitingly, we weaned off of her medication. She was on a low dose for a while, and then we finally got off that. So I think that shows the success to get kids off medications. And then lastly, overall quality of life. So on the left, you can see a list of all these quality of life measures, just how is she interacting and engaging in the day. Red is bad, green is good. And as you can see, moving towards the right, yeah, we got a lot more greens. And so certainly throughout all of this, it might not be necessarily something that we're measuring, but we certainly are seeing her quality of life being markedly improved. And hopefully we'll talk a little bit about that on the panel next. So I found this cute little picture because they shared this with me. This was far beyond me meeting her. But even as a little girl, this was one of her, I think, first rehab visits. And she had a spastic paraplegia, a lot of gait difficulties. And so the secondary outcome measure was actually falls. And I'll tell you about what we learned from that was that falls was a good measure at first because she wasn't necessarily walking as much. And so we actually saw a change over time because we learned that she wasn't in the wheelchair as much, and that ended up causing some issues later on. But I think that's kind of the goal of these trials, is to make it an iterative process. Yeah. I can't make it louder.
Where you got before?
My dance class.
Yeah. We're so thankful for you, Lauren.
And
So this is a little pre-video, and I just want to show you kind of what she was doing afterwards. She's a little bit older. This was right before her therapy. This is an example of her daily life where she was so out of it and not really engaged because she had so many spells. And spending a lot of time like that is probably not too meaningful for her or for other people.
I'm just gonna make it look like there's sunlight. Suze, is it okay if I make there be sunlight in the picture? No. What? Watching my show.
Nice, Suze. You're really good.
And we've seen more and more videos of her actually showing her parents to get up from sittings with a gower, but she wasn't even able to do that before. And so that's definitely some of the motor pluses that we've seen. This is more recently. Now I think this was just the summer. So she's sitting up, she's engaged. She often sends me videos in the morning singing me songs.
Please, one of those to get, like, if a person is trapped, you slam the door out, break the door, and then call the ambulance, and then get to the hospital, and
Well, and everybody stays safe, right?
second fire.
She could keep going. Now the point of that, no, the point of that seriously is that like she had a hard time getting through full sentences. She tells stories now. She sang the national anthem at a baseball game. She has really come far. That's certainly not something that we haven't been able to capture, and I'm not sure how we're going to capture that in our outcome measures, but that's certainly something to say. And her engagement and her enthusiasm working through school has been just phenomenal to see. So because of the safety that we demonstrated, we said, well, why don't we try this for somebody else who also would benefit from the same therapy? But let's try a little bit sooner. So we actually have our second case, who is another patient with KIF1A, so similar genetic defect. And this person is adorable, as you can see, and has a similar phenotype in that there's developmental delay. We're not at a regression point. Susanna really started having that regression around 4, and this individual hasn't really hit a regression. That being said, there is definitely delay, and we're starting to develop spasticity. We do have significant tremors. The optic nerve atrophy is already set in. And for this young lady, she does not have any epilepsy concerns. However, at this point, she's still at the age of 3. Actually, this video is still at 2. She is non-ambulatory and pretty minimally verbal and minimally kind of able to express her wants and her needs. She has a slightly different missense variant, but in the same gene, and luckily she was amenable to the gene therapy, the same gene therapy. And so in this case, again, she has a spastic diplegia, as well as some of the other global developmental delays. I can share more videos later. So for this individual, we tailored it a little bit. We learned from patient number 1, and now for her, because seizures are not as much of an issue here, we did want to prevent seizures, and we want to address that that's a concern. But for her, we were really worried, about mobility. We want to get her up and moving. And I think it's, wonderful to see people that we didn't even have it on the radar that they were going to be able to walk, as you just heard from the prior case. And so for her, the primary goal was mobility. The secondary goal was seizures. We kind of elaborated on some of the measures that we had learned from case 1. And then in terms of exploratory goals, I think for families that I've met, and communication is a struggle, that's always something people want to hear their child speak and hear their voice. And so that's certainly something I want to include in my protocols, but recognizing that that's more of an exploratory aim. And then sleep was a disturbance for some time, and so we wanted to say, could we make some improvements in our sleep? So at this point, as of a week and a half ago, we've had 4 doses. We've had the dose escalation. We're up to 80 milligrams, doing really well. So again, we're really early on this one, but I think the goal here is to show, again, she's tolerated it well. We haven't had any adverse effects. No regression, no seizures. We're gaining skills, and we're going to kind of see how can we maybe change the trajectory of her diagnosis. So this young man you actually met earlier. So this is Tayson, who shared our story earlier. Thank you, Stan. I deleted all those videos because you stole them first, so I can't show them now. But this is actually a video when I met Tayson in the clinic earlier this year. He has a disorder called DRPLA. I will not say it because it's very long, and it's caused by an expansion, a triplet expansion repeat in the ATN1, the atrophin 1 gene. And for him, he had more of a symptom onset at 2 years of age, characterized by ataxia, myoclonus, severe cognitive regression, and now a medically refractory is epilepsy. And so for him, I actually had to stop the video sooner because he actually had a seizure on the day that we were doing all of our baseline testing. And so for this patient, our goal was really to improve the ataxia. We felt that ataxia was a significant part of his clinical picture, and actually going back to the families and the researchers in the foundation called Cure DRPLA had actually recently put out a paper doing caregiver interviews. And one of the top, I believe, 100% of their patients said ataxia is the main concern here. So we should probably treat ataxia. So the primary goal was ataxia. We were hopeful that seizures can be improved because he is on 1, 2, 3, 4, 5. He sees somebody like you, a medically refractory epileptologist. And so we did want to improve frequency and seizure and length of seizure. We're a little too early to kind of say whether or not we're seeing things there. But similarly, exploratory-wise, we want to look at intellectual disability, cognition, language, communication. And he has also, as of a week and a half ago, had 4 doses, and we're up to 50 milligrams. And so I think for that, it's been early, but we're already seeing some promising things. So that was the one I was supposed to skip over. So we're going to skip this because you already saw that. This is a way old slide deck All right, so this was supposed to be the one that came last night, but clearly it didn't get updated. All right, so on the left is something called the SARA, and up here it's a scale of ataxia. So we use something called the SARA, and the higher the numbers, the higher the ataxia. And so actually, the updated slide deck is really great. It actually shows that we are down about 30%. The coolest thing was where I was going to show you guys that Dr. Anupam Gupta, head of MGH, has some gait sensor data. And actually what's really cool is that he doesn't even know when I'm doing my dosing, and he doesn't know when I'm doing my clinical tests, but luckily it worked out really well, where we're actually seeing improvement in those gait parameters with his sensors along with my clinical phenotyping. So just imagine that right there, and hopefully you'll see it soon enough. And then on the right-hand side is the seizures. So again, we've been using an app called Seizure Tracker to try to look at seizure count, duration, et cetera. We're only a couple months in. We've only had 2 or 3 doses on this Seizure Tracker. But we're starting to see some trends, and now we have to continue to evaluate and see whether or not that's been effective. And then my last case, because I know that I'm way over time, is on a gene called NRPH2. This is an RNA binding protein, so it works a little bit differently than the other two. So my patient Rosie on the bottom here. And girl, look at you go. We don't need the audio, so you can turn that down. But we can just see. For her, this young lady has had global developmental delay. There's been some motor aggression, a couple of periods of regression, mostly after illnesses, seizures, surgeries, for example. But now at 7 years old, she's non-ambulatory and nonverbal. And she does have epilepsy, not medically refractory, but it's there nonetheless. Cortical visual impairment as well as a dystonia. And so for her, we did change things a little bit because she doesn't have as much of a regressive phenotype. Actually, we're working on the natural history study as we speak. And so we're trying to learn kind of in parallel to that natural history study. She's a lovely, happy girl, but we really want to figure out how to get in there. So NRPH2, for those who don't know, if you have any patients, please reach out to me so I can connect you with the nonprofit. Is an RNA binding protein. We think that it also causes a toxic gain of function in some of these mislocalization variants. And we have over 50 individuals that are described with this. So for this young lady, again, we're trying to work on motor function, prevention of seizures, but those exploratory goals I think are very similar. And I'd be eager to see what the n-Lorem group is seeing as a whole in terms of what are those primary and secondary outcomes. I think that's going to be really important. She has now gotten 2 doses of study drug, the highest of which is 40, tolerating it well, no side effects, no regression or seizures, and she's doing quite well. So, because I'm way over time, thoughts about where my experience that I've been working on is, number one, what do we do after treatment? So I think somebody on the last panel was talking about, well, what happens after the trial period ends? Now what? I think that's something we all want to know. Interestingly, in year 2, we see things that we didn't see in year 1. And now we have to figure out, is that related to progression of disease, or is that something new? Perhaps new seizures, new falls, new things that we didn't see in the year 1. And I think what's really important is knowing that you have experience with one clinical trial, how can we use that to kind of push forward the next clinical trial and make it a meaningful iterative process. For example, we started using a different seizure diary. We started transitioning from a fall diary and a 6-minute walk test. How can we measure pain, things like pain for individuals who might not be able to communicate regularly, so fuzzy feet. Pairing quantitative data, such as wearable devices, might be really helpful. It probably is very helpful in terms of clinical scales. Getting information about ataxia, dystonia is certainly very helpful, and putting my plug in for really working with other collaborators at different institutions so that we're really maximizing our benefit. We definitely need to do a better job capturing tremor for individuals who can't necessarily do tasks. That's something that I'm learning and I'm trying to figure out myself. But I will say that many of the patients, I'd probably say 4 out of the 4, have had improved attention, awareness, eye contact, and that's not necessarily getting picked up in my outcome measures. And so we have to figure out as a field, how can we do that, and how can we, because it certainly is meaningful, but how can we pick that up? Daily skills are absolutely more meaningful. We know this. So how can we do that? How can we prove to the FDA that that's going to be enough, or that should be enough? Things like feeding themselves, dressing themselves, as you saw with Taysom putting on his socks and feeding himself now. And then lastly, ASO treatment. This is really important. So ASO treatment is definitely not a cure. Okay? It's a disease-modifying treatment. It's the first step. we're filling a gap that hasn't been filled before. But we definitely have a ways to go, and so I appreciate everybody. Thank you to the families who have, again, trusted me to put a needle in their back, and thank you to all the collaborators at Columbia and n-Lorem and everybody else out there who is willing to go through this together with the clinicians and scientists.